It says that we're streaming live, so good afternoon. It is not morning, and welcome to the first interim briefing of the House Health and Government Operations Committee. This is a virtual committee briefing, so I ask for your patience if we encounter any technical streaming issues, which sometimes we do. This briefing is being streamed on the Maryland General Assembly YouTube channel. Members will be muted throughout this briefing. If you have a question after the presentation, please use the raise hand function, which is located either underneath the participant list or on the right side of your screen, or under the reactions bar at the bottom of your screen. After I call your name, unmute yourself, please. Remember, even though we're meeting on Zoom, please refer to our usual committee rules of one question and one answer from the panel, not one question and one answer from each individual panelist. Also, please keep your questions brief. We will begin today's briefing with Secretary Anthony Woods from the Maryland Department of Veteran Affairs, who will provide the committee with an update on Charlotte Hall, followed by a question and answer session. And then next, we will hear from the Maryland Insurance Administration on the 2024 individual and small group health insurance rates, followed by a question and answer session. The briefing will conclude with another presentation from the Maryland Insurance Administration on high deductible health plans, followed by a question and answer session. We will begin with Secretary Woods in a minute. I just want to welcome everyone, and I want to thank you so much for making the time to be with us. I really appreciate it. I know everyone is busy, but when we have these hearings, it makes our lives a lot easier during session because we have so much going on during session. So I want to personally thank my wonderful staff and my members for being so flexible. Also, for my members, please keep your video on. It is a rule requirement if you're able to. And so we'll get started. And I just want to say thank you. We'll begin with Secretary Woods from the Department of Veterans Affairs. Secretary Woods, welcome to our committee. It is really a blessing to have you. And when you're ready, you can get started. Thank you.
Thanks so much. I appreciate it, Chair Peña-Melnick. I also just wanted to offer, I recognize that you all have such busy schedules. I don't quite know how you do it during the session. And then I also realize it's pretty much a full-time job outside of session. That said, yeah, absolutely. It is absolutely a privilege to represent the department. And I'd love to just offer right now that if any member would like a one-on-one conversation about Charlotte Hall, more than happy to provide that. We're also very happy to welcome guests, members of the legislature to Charlotte Hall. At any point that you'd like to do that, we could, of course, arrange for a visit as well. So please just know that this session is not the only space in which you could ask questions about performance at Charlotte Hall. So again, I want to thank you for inviting us to update you on operations at Charlotte Hall. Members of the legislature, especially Senator Bailey, Delegate Morgan, Delegate Crosby, and members of the Veterans Caucus, your partnership has been invaluable, and we welcome continued oversight as we all work to protect the interests of the veterans who live at Charlotte Hall. Before I start, though, I'd love to just sort of kind of call back to a moment that I had in May when I was walking out of Charlotte Hall during one of my many visits, and one of the residents who I've gotten to know kind of pulled me aside and was telling me about his experience. He had kind of a look of nervousness in his eye because there was a lot of change underway, and at the end of the day, this is his home, and he kind of gave me a direct look, and he said, it's important for you to know that you've got all of our lives in your hand, for better or worse, and we're all counting on you. And I realized the last time I had sort of been in a situation like that was when I was a platoon leader in Iraq, and the soldiers who I led, I was responsible for their lives. And so I just want you all to know that that's the level of seriousness and the level of gravity that I approach my responsibilities across the department, of course, but especially at Charlotte Hall. So as many of you know, Charlotte Hall Veterans Home has been serving those who've served since 1985. The 444-bed facility is situated on 126 acres in St. Mary's County. It offers a continuum of care from assisted living to skilled nursing. Our vision is to continually develop and deliver a safe, dignified, and compassionate healthcare system and provide a nurturing and engaging home environment for Maryland's veterans. Unfortunately, vulnerable veterans have suffered from poor care and insufficient oversight For too long, veterans at Charlotte Hall lived out their golden years in poor conditions and neglect. Governor Moore was right when he described the situation as a moral failure of government, and those words stung for me. They were very serious for my department, and we take seriously the work of rebuilding and restoring trust, not only with the residents, but with the public. In my early visits to the home, I heard firsthand heartbreaking accounts of life there, including stories of rodents, lack of healthy food, and inadequate care. These anecdotes were supported by independent inspectors, reports that showed our veterans were not being treated with the dignity and respect that they had earned. Since day one of the Moore Miller administration, my team has worked to overhaul the facility and to give veterans the care that they deserve. So I'm delighted to provide you an update on this 8 months of progress. So the MDVA has instituted 4 major reforms to improve conditions at Charlotte Hall. First, we found a new management contractor with the track record of that's necessary, we think, to transform the home. Second, we modeled the contract structure after what is used in other states for their high-performing homes to incentivize quality care and safety. This model ensures that profits are never put before the well-being of our veterans. Third, we set new guidelines for oversight at Charlotte Hall focused on collecting real-time data on healthcare quality measures consistent with industry best practice. And then fourth, the Moore Miller administration worked in partnership with the legislature to require contractors operating state-owned nursing homes, including Charlotte Hall, to provide notice of deficiencies and enforcement actions that are levied against a facility. This new reporting requirement, signed into law by Governor Moore last session, will increase transparency and help ensure better oversight and care of Charlotte Hall residents. And so I have an update related to that as well. Love to go over. To the first major step, in May, we awarded a new management contract to Pruitt Health, which began on June 6th of this year. Pruitt Health is a Georgia-based operator with experience managing 105 retirement homes, including 4 veteran retirement homes, actually, excuse me, 5 when you include Charlotte Hall, across the southeastern United States. 10 of their locations were recently recognized as Best Nursing Home for 2022-2023 by U.S. News and World Report. All the veterans' homes under Pruitt Health Management are recipients of the Joint Commission's Gold Seal of Approval for meeting the highest safety and quality healthcare standards. We're confident in Pruitt Health's demonstrated ability to consistently deliver high-quality care at its veteran retirement homes, which serve a unique demographic with special healthcare needs, which I think is also important to understand. Their veteran retirement home operations came with positive endorsements from my counterparts in other states as well, which I think was actually really important for me and gave me a lot of confidence. But I also want to be clear, responsibility for turning around Charlotte Hall will not be Pruitt Health's alone. Pruitt Health and the Maryland Department of Veterans Affairs, we're working together to turn Charlotte Hall around. We're working together to prioritize areas for corrective action, of which I would still say there are many, and to design the long-term turnaround strategy for the home, which will take years for it to return to a 5-star level rating. Since I last briefed the Board of Public Works in June, so the last sort of public comments on the situation at Charlotte Hall, I would say that we're making really good and continued progress. First, I'm pleased to announce that the recent hiring of Colonel Retired John Lombardi, who now serves as the State Veteran Home Program Director, which oversees all of our operations at Charlotte Hall. He brings a wealth of experience and a compassionate heart for veterans. He most recently served as president and interim CEO of Knollwood, which is a 300-bed continuing care retirement community for veterans in Washington, D.C., which I just had the opportunity to visit last week. And it's a beautiful space, and I hope to bring that kind of environment to our veterans at Charlotte Hall. John's extensive leadership experience in the military, healthcare, and long-term care settings gives me great confidence that he'll excel in this role. And so his experience will help us improve oversight and ensure that the quality care that we provide at Charlotte Hall honors the service of the veterans who live there. Pruitt Health, with my department's approval, which is an important point to make because of the way we have the contract structured, they have hired a new and very capable administrator for the home. Sonia Bailey Gibson is a healthcare executive with 30 years of experience in the specialty practice areas of senior care, skilled nursing, and assisted living care, amongst several others. Sonia has a record of success in leading people, building diverse and cohesive teams, creating strong cultures, and leading change management initiatives to include successfully taking a facility that had a 1-star rating and turning it into a 5-star rated facility. Her experience also includes opening the first state veterans nursing home facility in West Virginia. So we're very, very fortunate to have her skills at the helm at Charlotte Hall. And the two of them, both John and Sonia, work side by side in partnership to deliver care there. Together, we have also launched a new approach to oversight, which I think is obviously important to you all here today. During their first week, Pruitt Health transitioned Charlotte Hall to a total electronic medical record system called Matrix Care. This enables us to have real-time dashboard level views of clinical performance, which I think is really quite important. As a part of the transition, Pruitt Health also conducted a baseline assessment and observations of 249 veteran residents of the facility. This will be used to be a baseline as a baseline framework to measure future success against. Wrapping up here, so Pruitt Health also hired a full-time director of nursing after 4 different individuals occupied this role over the previous 12 months. So that kind of stability is quite important. Pruitt Health has also made steady progress rebuilding the full-time clinical staff, hiring 22 new nurses and GNAs in the last 4 months alone since the transition. By contrast, I'd also point out that no clinical staff was hired in the prior year, with increasing reliance on temporary staff or agency nurses. And so while I'm happy the transition of the management contractors went very smoothly and our efforts to rebuild the leadership team and improve the culture are making progress, as I've said in multiple settings, our work for transforming the facility has only just begun. So I mentioned at the top my appreciation for the new oversight requirements that you all helped to pass. But I would say the most recent inspection by the U.S. Department of Veterans Affairs offered me a reminder that we have a lot more work to do. And so this inspection found that we need to redouble our efforts to improve cleanliness and pest mitigation. And there was a medication error with 1 resident. And so while these deficiencies found do not rise to the scope and severity found in previous inspections that we all read about, and you all read about in the headlines, and that we had an opportunity to brief you on, my department and Pruitt Health have taken immediate action to correct them. So the subcontractor responsible for dietary and janitorial services has been notified that their contract is being terminated. This will allow Pruitt Health to take direct responsibility for these vital components of the operation. And then additionally, the temporary nurse who was responsible for the medication error has also been let go. Pruitt Health will be sharing their detailed corrective action plan by the November 7th deadline, which is required back to the U.S. Department of Veterans Affairs. So I'd like to also just quickly point out that the approach to addressing these survey findings is also vastly different than what my department has experienced with our previous contractor. And so both John, Sonia sat side by side as the U.S. Department of Veterans Affairs surveyors relayed their findings in person just a few weeks ago, meaning that my department, found out immediately exactly what it is that we need to work on and the deficiencies that we need to correct. And this is a stark change from how it was in the past. And then when the U.S. Department of Veterans Affairs shared their survey findings, Pruitt Health sent those immediately to us, which is a welcome change. And it's a sign of the partnership that we're building there. So as we move forward, we're committed to sharing our progress with the stakeholders represented here, especially the legislature. Pruitt Health and the Maryland Department of Veterans Affairs are working in lockstep to turn Charlotte Hall around and to take care of our most vulnerable heroes. These are the hard problems, but we must not lose sight of our mission, right? Governor Moore was elected on a creed to leave no one behind, which is a solemn pledge, and it's a promise to take care of the men and women who bravely risk everything. So our work to fulfill this oath is now underway. Our veterans deserve nothing less. So I'm excited to take questions from you all.
And thank you for your leadership and for the consideration you have to the committee and for the work you're doing. And I want you to consider us a partner. I'm going to open it up for questions now from our members. Before I do that, I just want to clarify the record that Delegate Lewis was in an Uber, not driving, and the other ones that are driving have pulled over. So we're very responsible here, okay? Who has any questions? Okay, I'm going to start with Delegate Bagnall. Please unmute yourself. Thank you.
Thank you, Madam Chair, and thank you, Mr. Secretary, for this report and for your attention to this concern. I just wanted to ask if you could give us a little context. You gave us some numbers on the new hires. I think it was 22 nurses. In the assessment, how much of an understaffing was demonstrated, and where does this put us in terms of the overall goals of getting to full capacity?
Yeah, so Delegate Bagnall, it's very good to see you again on this new topic, but good to talk with you. So you've raised a really important point. One of the things that I alluded to in my comments, but it's important to point out, under the previous contractor, unfortunately, almost 90% of all clinical care was being delivered by temporary or agency nurses. And, I don't want to say anything negative about temporary nurses. They deliver critical care in important settings and help facilities in need at times of crisis. But what's important to note is when you have a temporary or agency nurse, well, that person is not building a personal relationship with the resident that they're caring for. And what that typically means is, they're not familiar with the medications that this individual is taking. They don't know the types of ways that this person wants to be treated, right? And so what we have found that when mistakes are made, yes, you retrain that individual, but if that person's only there for a shift or a day or a week or a month, well, you're retraining a constantly evolving crew of individuals who are supposed to deliver care. And so we saw that so many of the sort of grievous infractions were coming from temporary staff who weren't trained properly and didn't have the ability to invest in their training. And so, like I said, 90% of all clinical care, the staff hours were being done by temporary staff. That's now actually been reduced to 55%, which is a really good sign of progress. And so I mentioned 22 clinical staff hires to date. They've really gone a long way. We've actually seen individuals who left from working at Charlotte Hall come back because they realize that something is up and there's change underway and they want to be a part of this. And I also just like to point out, one of the things I really appreciated in my early visits and came to understand very quickly, we have a lot of deeply dedicated individuals who work at that facility, some for 35 plus years, because they really care about the mission of caring for these veterans. And so I was excited to see new leadership and new culture goes a long way in creating a good workplace that they want to stay in. And that ultimately results in the best care for our veterans.
Thank you very much. Thank you, Madam Chair.
Of course, thank you.
Pleasure. Delegate Morgan.
Thank you, Madam Chair. Secretary Woods, thank you for doing such a great job with Charlotte Hall. I know you were kind of thrown into this situation when the new administration took over, and it was a difficult situation. You've all done an outstanding job as far as I'm concerned. Last year, we passed a bill through HGO that allowed the governor's office and the HGO committee and I guess the president and the speaker to be notified in case something ever happened at Charlotte Hall. It's just basically a notification bill. We just had our local delegation meeting a few days ago, and our local government would like to be notified as well in case situations like that. You don't see any problems with, that being an issue or some legislation coming forward this session, correct?
Yeah, Delegate Morgan, I just say thanks again for your partnership. You, Senator Bailey, Delegate Crosby, your relationships with not only residents and members of the staff there, you all are also providing great insight, information that helps to inform our strategy. So I just wanted to say thank you for that. I think you're absolutely right. There are local government entities, particularly the St. Mary's Department of Health, that actually they have a responsibility where they are essentially the responsible party for a number of residents who live there. So I think you're absolutely right. It would make perfect sense to share that type of information directly with the local government. I would also add, so I appreciated the speed at which you all helped to create legislation. I know that actually came, I believe, almost the last day where you all produced this legislation. So I appreciated that. One thing that I would actually encourage perhaps to consider during the next session is that right now the legislation pretty narrowly says the Center for Medicaid and Medicare Services, inspectors from them, or the Office of Healthcare Quality in the Maryland Department of Health. It encourages them, or it says that any survey findings from them have to be shared not only with the governor's office, but with the legislature. I would actually recommend expanding that because there are, as you know, there are a number of government entities at multiple levels, federal, state, and local, who inspect the facility. And if they find something alarming or negative or levy fines, I think you all in the legislature deserve to know that right away. And it's always helpful to have the law behind us if we were ever to find ourselves in a future situation where we had trouble accessing information. But again, I would say that Pruitt Health has been nothing but transparent. We're partners in this, and it's been a breath of fresh air to work closely with them.
Well, good job. And thank you for being so transparent and open about this and getting a grasp of the situation. Look forward to working with you in the future. Thank you so much.
Thanks,
And
Delegate Morgan.
and thank you, Secretary. Delegate Morgan, if you have the bill, will you be so kind and whoever has it, work with the secretary to make sure that it's drafted with his suggestions and with the local municipality notice so that he
Okay.
can see it ahead of time and then it's ready to go, right?
Okay.
So
Will do.
whoever has it, make sure they're communicating with him and let him see it, okay?
Yes, I will. Thank you, Madam Chair.
My pleasure. Delegate Hill.
Thank you, Madam Chair, and thank you, Mr.
welcome.
Secretary, for the good work and for presenting, being here today. So you mentioned the issue with nursing shortage and filling in with temp. And I'm sure that's not just Charlotte Hall. I'm sure it's not just the veteran system. So really a two-part question. Number one, what recommendations or lessons or what do you have for us to help us get a better grasp of how extensive this problem is and how we might address this going forward? We've been, trying to address shortages across the healthcare spectrum, but you may have some insights. And then I guess the second part is taking the extreme situation at Charlotte Hall. How are you and your department going about reviewing all of the care provisions at all the VA institutions here in the state?
Yeah, it's a great question. So Delegate Hill, I'd point out you're absolutely right that this is a national challenge and some might say a national crisis. So I think it'd be wise for all of us to be thinking very significantly about long-term care, geriatric care, what that's going to look like for Marylanders in the future beyond just veterans, right? The U.S. Department of Veterans Affairs estimates that we should have 1,108 beds or rooms or available for retiring veterans. And as I mentioned, Charlotte Hall at its maximum can only have 444. I'm very appreciative of the legislature's leadership on helping to earmark $63 million for the construction of the second home that would veteran retirement home in Sykesville, Maryland. And so we're moving through the design process there. The federal government has matched your contribution with $118 million of federal dollars, and that will allow us to break ground hopefully within the next 18 to 24 months. So that'll bring another facility online at some point in the second half of 2027. The other thing I would point out is my colleague, Secretary Rokes, with the Department of Aging, has a wealth of information. So I would just encourage any of you all or your chiefs of staff to connect with her. She was a partner in this work and helped to really help me understand some of the challenges we're seeing nationally. Where I've seen some promise in talking with the University of Maryland medical system. They actually have a number of partnerships where individuals can start their training at a local community college and essentially intern in a hospital setting or a care setting for pay. And what that allows them to do is simultaneously pay for their degree, come out of that degree program with no debt, and get on-the-job training in real time. And that type of pipeline is something that I would hope that we'd be able to set up for Charlotte Hall and to creating and increasing the sort of pathway for CNAs, GNAs, LPRNs, and nurses. And so I would think expanding those types of opportunity could certainly be one, and helping to forge those partnerships. That's where my focus is going to next. Particularly knowing we have a 128-bed facility coming online in Sykesville. That means not only do we need to grow our nursing pool and our CNA and GNA pool at Charlotte Hall, we now have another part of the state where we want to make sure there's a good, robust talent pipeline for healthcare professionals. So that's certainly one. Looking at scholarships or loan repayment opportunities is another one that might incentivize and encourage individuals with healthcare backgrounds to serve not only at a place like Charlotte Hall or Sykesville, but also at the Maryland Department of Health. The number of facilities that they operate And so looking for those types of scholarship opportunities has typically been what I've seen other states turn to, and can certainly be an option for us here.
Thank you.
Thank you.
And thank you, Secretary, for your patience as we ask these questions. Are there
Of
any?
course, I appreciate it.
Are there any other questions for the Secretary? Seeing none, thank you so much. I want you to, feel free and feel welcome to bring up any issues when we're not in session or during session, or just, give me a call, right? If you don't have my cell, ask your staff to ask my staff to give it to you. I
Will
would
do.
answer and let us know how we can partner, okay?
Thank you so much, Chair Peña-Melnick. And as I mentioned at the top, we're delighted to do one-on-one briefings anytime. As I've said, it has been, I'm glad the governor takes the approach and has told all of us to take the approach. We work alongside you as partners, and you all have only made our decision making better. And so we're excited to continue that partnership. Thank you.
Thank you. We appreciate you. You have a blessed day. Thank you for
You
being with
too.
us.
Thank you very much, everyone.
Our pleasure. Now we have actually the 2024 individual and small group health insurance rates. And we have the Commissioner for the Maryland Insurance Administration, Kathleen Moraine. Welcome, Commissioner. How are you?
Thank you very much. It's very nice to be here. It's nice to see everybody, and we're very pleased to present our rate results for the ACA market for 2024. Our Chief Actuary, Brad Boban, is going to lead our discussion today and is available to answer any of your questions.
And thank you so much for everything you do, for being available in the interim, all the phone calls, all the email and reports we request. You always do it with grace and humility, and we really appreciate it, okay?
Well, it is our pleasure. That is literally our job, is to be there to support your efforts.
Thank you very much. So we have Brad. Brad, how are you?
I'm good. How are you?
I'm doing well, and welcome to HGO. We're all yours.
Thank you very much for having me here today. I'll jump right into what we approved with the ACA rates. So if you could please go to the next slide. This is just a high level overview. In general, for all of our rate review, we are making sure that rates are neither excessive nor inadequate nor discriminatory. And we're making sure that they're reasonable in relationship to benefits. In the individual or in the ACA marketplaces in general, individual and small group, the key distinguishing from non-ACA markets is that health status cannot be taken into account in rating. And so they're guaranteed issue policies, and carriers have to use a single risk pool rating methodology where it's the average health status of the whole pool, and you can't take into account the health status of the members of any one plan. So when we get our rate filings in for this 2024 rate filing, the experience period was 2022 calendar year, and we begin by reviewing that experience period data from the carriers, both for the individual carriers, and my team, aggregates everything together, and we look at it for the whole market. We compare how 2022 experience played out, both compared to 2021, the previous year, and compared to how carriers were projecting 2022 to turn out. And then we, review the assumptions. Each carrier starts with their 2022 experience and then lays out assumptions to get to the 2024 projection period. And we review each of those assumptions individually and in aggregate, and make sure that they are reasonable and supported by data and analysis. Key assumptions for 2024, a lot of these are key assumptions every year, are the claims trend. We look at claims trend by both cost components, the cost per unit of a service, and the utilization components. How many services per 1,000 members are being utilized. We look at that also by the service categories. So carriers are giving us data by, inpatient, professional, or inpatient hospital, outpatient hospital, professional services, drug services. So you know, we analyze it by all these details. A second key assumption is the morbidity. You know, that's the relative health status of the pool. That's especially important in the individual market where there is a lot of year-to-year churn and where morbidity can change a lot. We review carrier operating expense assumptions and their profit margins / contribution to reserve assumptions. Unique to the ACA markets is risk adjustment transfers. You know, once again, you know, this is the whole, you know, single risk pool concept. Carriers who attract healthier than average members have to make risk adjustment transfers to the carriers that attract sicker than average members to help even out the premiums and make the premiums not reflective of health status differences. And then, you know, we have the COVID-19 impact. At this point, you know, that's mainly in the rear view mirror as far as ongoing claims go. But, you know, in analyzing claims trend, you know, we are generally looking at the past 3 years of data, and that includes 2020, where COVID and the shutdowns from the you know, the initial pandemic shutdowns greatly distorted the claims. So, you know, all the carriers needed to make adjustments for that, you know, when analyzing their claims trends. And then in the individual market only, the reinsurance recoveries under our state 1332 waiver are a key assumption, particularly for this year's rate filings. And then also in the individual market this year, we've got the impact of the Medicaid unwinding. You know, the public health emergency for COVID has ended. And, you know, as of June, people have begun to be disenrolled from Medicaid. This is an ongoing thing. It's going to take 12 months. You know, we're just starting to get the data. You know, so the carriers, you know, are in general not projecting a large impact because of this, but it's something, you know, that we're keeping an eye on, and that was a component of the projections. All of our ACA rate filings got submitted back on May 22nd, and we approved them on September 18th. So next slide, please. So in the individual market, carriers originally asked for a 5.7% increase when they filed back in May, and the final approved average was 4.7%, so it came down by about a point. CareFirst PPO and United, which comprise about 17% of the market, rates are decreasing on average for those carriers. And then we've also got Aetna, who is entering the market for 2024 with 9 plans that are being offered statewide. So United had entered the market a couple years ago, and so with Aetna's entering, that means all counties in Maryland are now going to have 3 carriers, up from 1 carrier, just CareFirst a few years ago. And the metro counties will have 4 carriers to choose from. And then, you know, as I was saying, a key component of rate review this year was reinsurance. As a reminder, last year, the state lowered the reinsurance attachment point of the program from $20,000 to $18,500. This was because when rates were approved last year for 2023, the federal government had not yet extended the enhanced subsidies under ARPA. And if those were not extended, there was a potential for significant double-digit increases because of the effect of all those people getting ARPA subsidies leaving the pool and increasing the morbidity. So to avoid that possibility, the attachment point was lowered, and that helped to lower last year's rate increases. So for 2024, ARPA was extended by the Inflation Reduction Act until the end of 2025. And you know, in the interest of the long-term solvency of the reinsurance program, the MHBE board voted to increase the attachment point back up to $20,000. So that's the same level as it was from 2019 to 2022. So this put about 1.6% upward pressure on rates. So had the attachment point remained untouched, and we didn't change it last year to you know, protect against its large rate increases, you know, last year's approval would have been a little over 8%, and this year's approval would have been close to 3%. But because of the attachment point, that's why we're at the 4.7%. And you know, on a high level, you know, the low increase is driven by 2022 claims coming in lower than carriers were projecting, and by carriers also projecting, you know, fairly low pricing trends into the future. A 5.3% average. This is a low, but by historic standards and compared to the group markets. So, you know, these are the main components that went into these approvals. If you could please go to the next slide. This shows the average approvals by carrier. You know, it's the second to last column shows what was approved. So, you know, the highlighted yellow number, 4.7% average, but you can see Care First Blue Choice is going up 4.9%, very close to the average. The Care First PPOs, as I say, are going down 2.5%. Kaiser is raising their rates by 8.3%, and United lowered their rates by 1.2%. And then we have Aetna new in the marketplace. In general, even with these rate increases, you know, the reinsurance program has brought the rates down so that on an absolute value basis, we are still 22% lower than we were in 2018. The year before the reinsurance program started. So despite, you know, years of claims trends, you know, the premiums are still lower. And, you know, the Maryland individual premiums started as amongst the lowest in the nation. We're the lowest on bronze and gold, and we're the third lowest on silver. And we don't anticipate that should change. And as a reminder, in the individual market, you know, all of these increases apply to those people that are paying the full premium themselves, which is only about 30% of the individual market. About 70% get premium tax subsidies from the federal government, and they are not going to see these increases. You know, how their premiums will change will depend on their income and how, in the second lowest cost silver plan. And that is shuffling, and members, like they should every year, should look at their premiums, look at their renewal premiums, and look at other options, you know, especially with Aetna entering the market with competitive rates. But you know, only the people that are paying unsubsidized full premiums are going to directly see these rate changes. And these are averages. You know, each carrier has, you know, multiple plans on multiple metal levels, and there are variations by the metal levels. All right, next slide, please. So as far as the other component of the individual ACA market is the dental. Dental carriers requested an average decrease of 1.3%, and that is what we ended up approving. 75% of policyholders who have an individual dental policy from the marketplace will be getting decreases. There are two carriers raising rates, Alpha Dental and Delta Dental, but their increases are equal to the decreases they implemented last year. So over the 2-year period, it's a rate hold. And just in general, claims in dental remain incredibly low compared to medical. Next slide, please. This shows the actual rate changes by carrier. You know, you can see the last two columns are equal to one another. We approved what the carriers initially asked for. As I say, it's a minus 1.3% average, but it's from, you know, minus 3.2% for the members in Care First dental policies to plus 4.2% for those in Alpha dental policies. And you know, as I indicated, the dental claims trend has been pretty low and pretty stable. All right, next slide, please. So the third ACA market is the small group ACA marketplace. Carriers in the small group market requested an average of a 7.5% increase back in May. We ended up approving an increase of 6.9%. Just like the individual market, there is a wide range of variation by carrier, but in the small group market, there are no carriers filing for decreases. All of them are filing for at least a small single-digit increase. The major driver of the rate increases approved in the small group market are our claims trend. The experience period, the 2022 claims for small group came in slightly higher than the carriers were projecting. The ongoing trend of 7.8% is significantly higher than individual. As far as what service category is driving that, prescription drug is the main driver. Prescription drug had been in mid double digits, 10 to 15%, a few years ago, and had moderated down to high single digits in recent years, and is starting to increase again back into those double digits in the small group market. While the 7.8% is a lot higher than small group, this trend is in line with large group trends and with national trend surveys that are in general seeing group trends, on the increase. Just to clarify, even though the trend in small group is higher, the claims level in small group is still significantly lower than individual. So, for the 2022 experience period, when we look at the actual claims, carriers are spending, a little over $500 a month per member in claims for small group. And for individual, that's over $623 a month. The trend is the rate of increase within the market, but overall, small group claims remain significantly below individual, and that's why the reinsurance program is needed in the individual market at this point, and that is what brings the individual premiums down. But the pure claims are higher. Next slide, please. So this shows the detail. I'm sorry if there's a lot of numbers on here. The average 6.9% I'm referring to is in the bottom right. That is the average for all carriers and for all quarters. That's another thing that is different between small group and individual. For individual, the rates are set for the whole year, but for small group, rates change quarterly. So carriers pre-file trend increases, and the quarterly increases, vary slightly. It mainly depends on how this year's trend compares to last year's trend, and if carriers filed any mid-year rate increases last year, because if carriers see that their trend is coming in higher, they're allowed to file a mid-year increase and update the pre-filed trend they have. And so that has happened in recent years. And so that that is why the pattern by quarter is it goes up and down. It depends on what happened last year. But overall, the variation by quarter is not very much. It's 7.4% in first quarter, 6.4% in second quarter are the high and low averages. And then you can see by carrier, some carriers in the single digits, and some carriers, the highest approved increase is an average of 15.4%. Next slide, please. At that point, I'll open it up to questions. I have an appendix that shows premium examples. I wasn't intending to walk through that, but if anybody wanted me to, I could. But otherwise, I'll take any general questions about what we approved or the rate review process in general.
And thank you so much for your presentation and your work, and for always coming to our committee with the important information. So I'm going to start with my Vice Chair Collison, followed by Delegate Hill, followed by Bagnall, followed by Robin Lewis. This is the way I see it. Delegate Collison.
Thank you very much, Madam Chair, and thank you, Brad, for such a clear presentation. So there are a couple of places where there were real dramatic differences between the requests. In the individual market, Kaiser was was asking for a much bigger increase and actually had a bigger increase. In the small group market, it looked like Aetna or United were asking for significantly larger increases and got them approved. Are there particular factors that contributed to those particular plans? Or is it, this is all just rolled into the overall calculation for the whole entire pool?
Yeah, thanks for the question. I would say most of that carrier variation is dependent on where they're starting in 2022. Kaiser in particular is underpriced. When you look at their financial statements, that they are losing money in the individual market. They have a loss ratio of over 100%, which means they're paying out, more in claims plus risk adjustment payments than they're collecting in premium for 2022. And so that in particular is why they were asking for a higher increase than average. And in general, the carriers that are asking for particularly low increases generally tended to have better 2022 results, lower loss ratios, and they want to stay above the minimum. So that's the primary driver of carrier variation.
Okay, thanks. That's very helpful. Thanks.
Thank you. Delegate Hill, followed by Bagnall.
Thank you, Madam Chair, and thank you,
pleasure.
Mr. Boban. Can you go back to slide number 7 and point item number 4? Where you were talking about the small group versus the individual market and what they're paying per claim. And this may not be information you have, but if you do, I was just wondering, when we see this distinction between individual average 623 per claim versus 502, or per member, I guess, not per claim, or per member per claim, whatever. Maybe you can clarify exactly what that is. But what I'm confused about, or what I'd like to have a better understanding is, are we saying that the individual market claim is a greater severity, less efficient in the way the healthcare is being delivered, different contracted reimbursements to the providers of the care, or is there, some other elements that would explain this difference? And because we're both hit by prices going up and by providers, not the corporate providers, but the individual people providing the care, be it nursing or physicians or whatever, saying that they're being underpaid. So I'm just trying to get a sense if we should be celebrating the SG or not. And you may not be able to, but anything you can share to flesh that out a little bit.
Sure. And just to clarify, those numbers are the average monthly spending per member per month. So in an average month, a carrier is and this is not carrier spending. These are allowed amounts. So this is the total amount of what the carrier pays in claims plus what the member pays in their cost shares. But yes, it's a monthly amount. The differences are mainly driven by morbidity differences. The individual market is a higher risk, higher, worse health status than the small group market on average. The gap has been narrowed. In past years, there would have been a larger percentage gap than there is today. The reinsurance program has helped reverse that, but ultimately, the small group market has been a stable market for decades, thanks to Maryland small group reform, where ACA, disrupted a status quo for the individual market, and it changed from underwritten, where you could only get a plan if you were relatively healthy, to guaranteed issue. It caused the individual claims to skyrocket, the reinsurance program helped stabilize that skyrocketing claims, and the pace of claims increase has certainly moderated the individual market. But ultimately, it is because the individual market attracts, sicker members on average.
Okay, Madam Chair, may I just follow up?
Yes.
Thank you. So if I understand you, since we're talking about different severity and different morbidity, populations, we should see a difference, right? And when we see that difference narrowing, it may be because we're artificially imposing restrictions on the cost of care, whereas the cost of care may not actually be going down for those individual market people. Was that a fair statement?
I mean, the 1332 waiver in the individual market is what keeps the premiums down. But it does so by covering a portion of these claims. And so, you know, in general, claims in both the individual market and the small group market are rising. I mean, claims trend is an ever-present thing. I think, you know, it would be not reasonable to expect claims not to go up, but we want them to go up at a reasonable pace, you know, slower than general inflation ideally. But yes, I mean, the reason the individual premiums are low are because we're taking a you know, almost a third of the individual claims out of the market and covering them with the reinsurance program.
All right, thank you. Thank you, Madam Chair.
Thank you. We have next Delegate Robin Lewis, followed by Delegate Taveras.
Thank you, Madam Chair. Thank you, Commissioner Bahrain and Mr. Bobin. This is very interesting and helpful. I wonder if you could speak to a question on enrollment trends with specifically for ACA dental plans. Is this a good setting for talking about that? I know we're talking about rates, but you did mention ACA dental plans. So I'm just wondering, since that's a relatively new market in Maryland, and you mentioned that rates were falling and that claims trends were low. So I wondered, what is the market for dental plans under the ACA look like? How many Marylanders are enrolled? Who are they? And why are the trends low? The claims trends low?
That's a lot of different components. I can definitely speak to some of that. You know, as far as enrollment goes, the dental enrollment was increasing very significantly, large double digits. I think, you know, the exchange has done a lot of outreach and you know, helped to market these plans. You know, I have those specific enrollment numbers. I could certainly share them with you. I will say that in generally, you know, the enrollment increases have slowed. You know, we had 3 years of really high double-digit increase, and I think the enrollment is still increasing, but now at a slower pace. It's leveling out. Overall, you know, it's, you know, a little under 100,000 people, and the whole market is 230,000 people. So, you know, less than half of people add on a dental policy. But, you know, I'm not sure what the ultimate upper threshold of that is. You know, ACA dental offers a good value, but it's, you know, you can also buy dental plans off the exchange, and you know, we don't track those numbers in the same kind of detail. As far as why claims trends are so much lower, I mean, I just think in general, you know, there is a much lower variance in claims cost in the dental world than in medical. There are not ultra high cost dental services that even a high cost dental service is not that much higher than you know, the average, where in medical, you know, you have $1 million claimants, and there's no analog in the dental world. And I also think, you know, there's not very much dental innovation going on necessarily. I mean, a big part of the medical trend is utilization, especially of specialty drugs. There's a lot more specialty drugs on the market today than there was a decade ago, and the utilization is much higher, and dental utilization is pretty steady. You know, everybody that's going to use a dentist is using the dentist.
That's helpful. Thank you. Thank you, Madam Chair.
My pleasure. And thank you for being patient, Brad. Really appreciate you. We have next Delegate Taveras.
Thank you, Madam Chair. And I apologize, Mr. Bowden, if you've already responded to this question and I'm just not understanding it clearly. It's kind of like a two-sided question. What is the difference necessarily? You said that the sicker individual joins the individual market, and exactly who joins the small marketplace, the small insurance. So what's the difference between the two, and why is there such a significantly high increase in the rates in the small? Like, it seems that there's such a steep increase across the small group compared to the individual. And again, I'm sorry if you already kind of responded to this in another way. I just wanted to make sure I was clear on that response.
Sure, I'll try to answer both of those questions. I think fundamentally, the reason why the individual market is less healthy than the small group market is more anti-selection. Anti-selection is where healthier people are less likely to pay a given premium, and sicker people are more likely to pay a premium. In the small group market, every employer subsidizes a portion of the premium, and the premiums that the employer actually pays are affordable. We're doing our best in Maryland to make premiums affordable for everybody, but in the individual market, if you're not eligible for federal subsidies and you're paying the full cost, that full cost is more than the employee only portion of a small group premium. And there's more anti-selection, and there's more incentive for the healthy people to say, I'm going to skip being insured. And that's why, I think small group has more healthy people. It's not that individual has more sick people, it's that they fail to attract as many healthy people as the group markets, and they don't have as many healthy people to offset the claims.
So just as a 3-year-old, just to me, the individual is the general marketplace, that's through ACA, and the small group is the job-related insurance places that exist in the market if you were to have a job, correct?
Yes, the small group market is offered by your employer. It's employer-sponsored insurance, and the individual.
And so why are the small market so much higher?
Yes, as far as the increases go, the percentage increases are all driven on where the rates are today and where the claims are relative to the current level of claims. So even though the small group claims levels are lower than the individual claims levels, the current premiums for small group and the year-over-year changes in small group trends are higher, and so a higher increase is needed in the small group market.
So your jobs are killing you. I'm just sorry.
Delegate Taveras, do you want to ask some questions offline so that you can get an understanding of how it really works? Because this has been a lot of years of working on all these products. It is they're doing really well thanks to the work of the General Assembly in stabilizing the insurance market and keeping premiums low. We're going to hear next on some of the issues we do have left, like the high deductible health plans, but I want you to really get an understanding. I know this is a very complicated issue, and I know that the commissioner and Mr. Boben will make themselves available, okay?
Okay.
My pleasure. My pleasure. Are there any other questions for, any other questions regarding the small group health insurance rates? Seeing none, I want to thank you, Brad, for being so patient, okay? with all of us.
Thanks
We
very
really
much.
appreciate it.
I'm happy to answer any additional questions anybody has. Feel free to reach out and contact me.
My pleasure. And thank you for your hard work because it's really working. It really is. Next, we're going to get an overview of the high deductible health plans. And Commissioner, you're on again. If you can let us know who will be presenting from your team and yourself, we're all ears.
Thank you. Well, we're happy to present actually David Cooney, who's our Associate Commissioner of Life and Health, and then Brad again, who you've just met as our Chief Actuary, are going to present the slides. And then we have a number of members of our staff here who are available to ask questions as if we need to switch out some of the areas of focus. So with that, I will hand it over to David to kick it off.
All right, thank you, Commissioner, and thank you, Madam Chair. It's a pleasure to be here. We can move on to the next slide. And we skip one more. There we go. So the concept of a deductible is one of the most fundamental cost-sharing principles used with insurance products. And it's designed to keep premiums lower by shifting some of the costs of the insured risk from the insurance company to the policyholder or covered person. In health insurance in particular, the deductible is the dollar amount of covered medical expenses that must be incurred by the covered person before the health plan will begin to pay covered benefits. So there's been a lot of research studies and media stories in recent years highlighting the steady increase in the average deductible amount for health insurance plans over the last decade or so. And as concerns have been raised with the affordability of healthcare and with ensuring that consumers have access to meaningful health insurance coverage, high deductible health plans have been the focus of much greater scrutiny and often criticism. In general, however, higher deductible plans will have lower premiums than other plans. So when you hear the term high deductible health plan, you may just think this refers to any health insurance policy with a very large deductible. However, this is a term that has a very specific meaning under federal tax law. Section 223 of the Internal Revenue Code defines a high deductible health plan, or HDHP as they're also known, as a health plan with an annual deductible not less than the minimum amount set by the IRS each year, and with a limit on total annual out-of-pocket expenses for covered benefits that does not exceed the maximum amount set by the IRS each year. And the IRS plays a role here because HDHPs are qualified to work with certain tax-advantaged accounts. So for calendar year 2024, the minimum deductible amount for an HDHP is $1,600 for an individual and $3,200 for a family, while the maximum out-of-pocket limitation is $8,050 for an individual and $16,100 for a family. Generally, under federal law, an HDHP may not provide benefits in any year until that minimum deductible for the year has been satisfied. Federal law does provide a safe harbor that allows benefits for preventive care to be paid before the deductible is satisfied. And federal law and associated guidance define preventive care, and the federal definition preempts any conflicting definition under state law. So if additional services or supplies are covered pre-deductible as preventive, those plans may end up losing their tax advantages. Next slide, please. There we go. So I thought it'd be helpful to provide a little history for high deductible health plans because there may be some misconceptions regarding the association between the Affordable Care Act and HDHPs. The genesis of HDHPs really has nothing to do with the ACA, and the ACA did not directly alter the federal requirements for HDHPs. HDHPs are a type of consumer-directed health plan, also known as a CDHP. And this is a category of health plans designed to increase consumer accountability for healthcare spending by combining tax-advantaged payment accounts with high deductibles. Health spending accounts may be funded by a combination of individual and employer contributions, and amounts may be withdrawn from the account on a tax preferential basis to pay for qualifying medical expenses, which could include expenses that are not paid by the individual's health insurance plan because the deductible has not yet been satisfied. The history of HDHPs under federal law predates the ACA, going back to 2003, when the U.S. Congress enacted the Medicare Prescription Drug Improvement and Modernization Act, which created health savings accounts, or HSAs. Eligibility to establish an HSA is conditioned on the individual being enrolled in an HDHP that satisfies those IRS criteria that were described in the preceding slide. So for this reason, we'll often refer to HSA compatible high deductible health plans to differentiate these plans from other plans that just have large deductibles. And this HSA compatibility is a very important consideration for these plans because the HSAs that are paired with HDHPs offer many advantages over other tax deferred or tax exempt health spending accounts, such as HRAs, FSAs, and MSAs. We can move on to the next slide. So highlighting some of the advantages of HSAs, unlike health spending accounts that are funded solely by the employee or solely by the employer, HSAs can be funded by a combination of employee and employer contributions. All employee contributions are tax exempt, and the account funds accumulate interest, which is also tax-free. Withdrawals from the account then will also be tax-free as long as they are used to pay for qualifying medical expenses. Because the HSA is owned by the individual, the funds are not lost if the individual changes jobs or resigns, retires, or is terminated. The account is fully portable and will follow the employee. In contrast to certain other types of health spending accounts, unused HSA funds at the end of the year are not forfeited, but they're carried over year to year without penalty. HSAs can also be used as a retirement savings vehicle. When an individual reaches age 65, funds may be withdrawn to pay non-medical retirement expenses without penalty at the individual's current tax rate. Additionally, although account contributions are no longer permitted once an individual becomes eligible for Medicare at age 65, the remaining accumulated account funds can be used tax-free to pay Medicare premiums and other qualifying medical expenses, such as cost sharing under a Medicare supplement policy. Next slide, thank you. So, depending on an individual situation, there are advantages and disadvantages to purchasing a high deductible health plan, and various factors should be considered when evaluating these plans. Starting with the positives, the major benefit of an HDHP is that premiums will be significantly lower as compared to a corresponding plan with no deductible or low deductible. For this reason, HDHPs are very attractive to healthy individuals without existing chronic health conditions who are looking to save money on health insurance and who do not anticipate needing significant non-preventive medical care. Furthermore, some people with serious illnesses who know they will reach their out-of-pocket limit. For these people, the combination of premiums and out-of-pocket expenses may actually be lower with a high deductible plan than a plan with a higher premium but lower deductible. Additionally, when HDHP is paired with an HSA as it's designed to be, there are very generous tax benefits for the individual, which were described in the previous slide. This makes HDHPs very attractive to consumers who actually have enough resources to sufficiently fund the HSA to fully cover the deductible amount. Also, many employers, particularly large employers, will contribute additional funds to the HSA account on behalf of employees, which can reduce the burden of the large annual deductible. Finally, it's important to note that under the IRS guidelines, the maximum annual out-of-pocket limit for an HDHP is actually lower than the maximum annual limitation on cost sharing allowed under the ACA for non-HDHPs. This means many non-HDHPs may actually require an individual to incur higher total out-of-pocket expenses before the plan begins paying 100% for covered benefits than would be required under an HDHP. Next slide, please. Turning now to the disadvantages of HDHPs, the most obvious one is the large deductible, which means the consumer will generally have to pay all expenses out of pocket, except for certain preventive services until the deductible is met. These expenses can be significant, and the high deductible may encourage some consumers to either delay or forego necessary medical care, which can ultimately lead to more serious and costly medical problems down the road. Due to the IRS guidelines, there are very few services that are permitted to be covered by the HDHP before the deductible is satisfied. While federal law does include a safe harbor for preventive care, state legislators and insurance companies are very limited in their ability to ease the financial burden of these plans, which I'll discuss more on the next slide. So HDHPs are not going to be ideal for individuals with chronic illnesses or those with significant anticipated medical expenses, such as an upcoming pregnancy and childbirth, who lack the finances to fund the HSA to cover the pre-deductible expenses. There's also no requirement under federal law for a person who purchases an HDHP to actually establish or fund an HSA. Therefore, many individuals covered under HDHPs may not have any funds set aside to pay for medical expenses incurred prior to meeting the deductible. This can especially be a problem when an individual lacks alternative plan options to select from other than an HDHP. So while consumers in the individual ACA market, they may select from a variety of plans, including HDHP and non-HDHP options. And while large employers will typically offer several different plan options to employees, the same is not always true in the small employer market. Many small employers may only offer one plan option to employees, and it could be an HDHP. And since small employers are much less likely than large employers to contribute to an HSA account on behalf of the employee, there is a greater likelihood that these employees will fail to have a sufficiently funded HSA to pair with the HDHP. Next slide, please. So there have been a variety of state and federal actions related to HDHPs. The federal tax guidelines for HSAs preempt any conflicting state requirements. So it's very important for states to be wary of inadvertently disqualifying state residents from the tax benefits of HSA-compatible high-deductible health plans. There have been many well-intentioned laws proposed by state legislatures across the country that have run afoul of the IRS guidelines for HDHPs. The state laws may apply to the insurance policy, but that will mean the policies can no longer be used with HSAs, so the covered individuals will lose the tax and savings advantages. As noted previously, there are also plans that have high deductibles, but they do not qualify as HDHPs under the tax code. Some ACA bronze plans, for example, will have high deductibles, but there may be reasons that the health plan does not qualify as an HDHP that can be used with an HSA. So state laws may then distinguish between HSA-compatible high deductible health plans and other plans with high deductibles. However, if a state mandates coverage for a particular service prior to the satisfaction of the deductible, a conflict with federal law may occur if the state requirement fails to include a carve-out for HSA-compatible high-deductible health plans. And this is because, as explained earlier, an HSA-compatible high-deductible health plan generally may not provide any benefits in any year until the minimum deductible for that year is satisfied, except with respect to preventive care. And while the IRS has issued various notices since 2003 to clarify and slightly expand the definition of preventive care for the purposes of determining HSA eligibility, the federal definition is comparatively narrow. And consequently, there have been three main areas where state actions have had unintended consequences for HDHPs. First, a handful of states have passed legislation related to so-called copay accumulator programs, requiring insurance carriers to apply drug rebates, coupons, and discount cards towards satisfaction of an individual's deductible, even though the individual does not actually incur any out-of-pocket expenses for the amount that is rebated or discounted off the price of the drug. So the IRS actually specifically put out guidance in 2021, affirming that the minimum annual deductible under an HDHP may only be satisfied by actual medical expenses the covered individual incurs. So consequently, consumers covered under HDHPs in these states could be subject to tax penalties if they use a prescription drug coupon or rebate to satisfy any part of their deductible. Second, many states have passed laws mandating first dollar coverage of certain non-preventive services. If these laws are applied to HDHPs, then consumers with HSAs in that state may be subject to tax penalties. This issue has arisen in Maryland multiple times, and it dates back to 2005, where we had an existing law that was already on the books when the HSA requirements came out. And so the General Assembly actually had to pass emergency legislation in 2005 to provide an exception for HDHPs to the existing requirement that all carriers must cover home visits for mothers and newborns without imposing a deductible. In subsequent years, the MIA has worked very closely with the General Assembly to ensure that any first dollar mandates do include an exception for HDHPs when it's necessary. And then finally, even though a state may define a particular service as preventive care, if the state definition is broader than the IRS definition, this can still create conflicts with the HSA rules. This issue came to a head in Maryland and 3 other states a few years ago when laws were passed prohibiting carriers from imposing a deductible on coverage from male sterilization. Although the state legislatures considered male sterilization to be a preventive service, the IRS published guidance clarifying that male sterilization did not satisfy the federal definition. Thankfully, the guidance did provide transitional relief that allowed states to amend their laws to provide an exemption for HDHPs so that the state residents did not become subject to any federal tax penalties. So all these federal preemption issues really demonstrate that any meaningful actions to ease the financial burden of HDHPs must occur at the federal level. Thankfully, there has been some movement by the feds in recent years to broaden the permissible first dollar benefits under HDHPs. In 2019, the IRS issued guidance establishing the most expansive definition of preventive care to date, which provided that certain medical services, items, and drugs for specified chronic conditions may still be classified as preventive care for the individuals with those conditions. The guidance provided an exhaustive list of 14 specific services and items for particular chronic conditions that were deemed to satisfy the new criteria. And it included a commitment by the IRS to periodically review and update that list. Then we saw a couple of things happen during the COVID-19 public health emergency. First, the IRS issued guidance providing temporary relief, allowing all COVID-19 testing and treatment to be covered pre-deductible under an HDHP. That temporary relief, however, will end on December 31st, 2024. And then Congress also revised the HSA law itself during the public health emergency to provide a temporary safe harbor for the absence of a deductible for telehealth. And that will also remain in effect until December 31st, 2024. Then the surprise billing prohibitions under the Federal No Surprises Act, they required a revision to the HSA law as well. And language was added to the Internal Revenue Code to clarify that first dollar benefits for non-preventive care that's required under an HDHP as a result of the No Surprises Act, that will not impact any eligibility for an HSA. Finally, the Inflation Reduction Act of 2022 added a safe harbor to the HSA law, allowing selected insulin products defined in the law to be covered pre-deductible under an HDHP. So if you look at all these changes individually, they may not seem that significant, but really when you look on them in the aggregate, these have resulted in meaningful enhancements to HDHPs over the last couple of years. And as we move on to the next slide, I'll be turning things over to my colleague, Brad Bobin.
Thanks, David. So I'm going to cover specifically how HDHPs interact with the ACA regulations. So in the ACA markets, individual and small group, all plans have to fit into one of 4 metal levels. A metal level is defined by actuarial value, and on a high level, that's the percentage of the total claims that the insurer is expected to pay. So that total allowed claims of 502 for the small group or 623 for individual, what percent of those total claims, and the targets for the different metal levels are 60% for bronze, 70% for silver, 80% for gold, and 90% for platinum. There is de minimis variation permitted, so carriers don't have to design their plans to cover exactly these percentages. Originally, the de minimis range for all metal levels was plus or minus 2%. So as far as high deductible health plans and fitting into these metal levels, platinum, it's impossible to have a high deductible health plan on platinum. Platinum covers 90% of benefits and has to, by definition, have a very low deductible. Platinum plans generally have no deductible. Gold high deductible health plans are barely possible. You have to have a deductible that is close to the IRS minimum, and you have to have an out-of-pocket max that's way below the IRS maximum. These are sold by carriers in the small group market. These are not sold by carriers in the individual market. Silver is probably the most natural fit for where HDHPs belong. A silver HDHP can have a deductible generally from about $1,600 to about $4,000. And these are sold in both markets and are extremely popular in the small group market. And then as far as bronze metal levels go, under the original regulations, HDHPs were actually too generous for the original bronze range. But because of the out-of-pocket max that was set at a lower level than the general ACA out-of-pocket max. So back in 2016 or 2017, the de minimis range for bronze was expanded to plus 5%. And you can only use this expanded bronze range for plans that are either HDHPs or plans that exclude one major service category completely from the deductible. And so bronze HDAPs are now possible with that change, and are sold in both markets. And they're the most popular HDHP in the individual marketplace. Next slide, please. So back one, please. Yeah, there you go. Thank you. So at a high level, I want to talk about HDHPs versus the value plans in the individual marketplace. You know, the actuarial basis behind HDHPs was the theory that if you put consumer skin in the game and had them see the cost and experience the cost by paying this high deductible, that they would avoid unnecessary services. That utilization of inefficient or unnecessary and wasteful services would be reduced. You know, in the decades since HDHPs have been around, you know, that there's data to show that they are reducing that wasteful utilization, but they're also reducing good utilization, medically necessary high value services. And you know, these are things like generic drugs, you know, where, you know, for a long time, you know, the generic drugs to manage chronic conditions like blood pressure and high cholesterol were not part of you know, what were outside the deductible for HDHPs. You know, David just went through how that's a recent addition to that safe harbor. But it's stuff like this where you know, by spending money in advance, you know, you can well control these chronic conditions and avoid the high cost hospitalizations that the result when the conditions are not well controlled. So, you know, kind of the next generation of plan design is what's called value-based insurance design. VBID is the acronym it goes by. And that seeks to, you know, remove the cost sharing barriers from those high value services. And so, you know, some of the changes that the IRS has made were due to, you know, VBID organizations advocating for these changes. And in general, the value plans on the individual marketplace also follow these principles. The value plans first were launched in 2019. They've been kind of evolving since then. Starting in 2024, the value plans are going to be standardized for all carriers. They will all have the same services, not subject to the deductible, and the same copays on all these services. For value plans, the types of services that are being excluded from the deductible are PCP visits, mental health, substance abuse visits, generic drugs, urgent care, lab test, x-rays, not high cost imaging like CAT scans and PET scans, but low cost x-rays, and PTSTOT, physical therapy, speech therapy, occupational therapy. So in general, you know, there is a value plan on bronze through gold. Each carrier has to, you know, offer those three value plans, and on every metal level, these service categories will not be subject to deductible. They will be subject to copays, but from day one, the member will be paying a copay instead of the deductible. So next slide, please. So this is the enrollment data that we have for the individual marketplace to show the selection of plans. And we put the plans into three categories: HDHP, value, and other plans that are neither HDAP or value plans. And so, you know, on the left, in the individual market only, we have this catastrophic plan at the top. That's for young adults under the age of 30. It has a standardized plan by the federal government. It's not a high deductible health plan. It has a high deductible of $9,100. But it covers 3 non-preventive PCP visits, not subject to that deductible, and that what makes it not qualified. And also the deductible is too high. So this catastrophic plan is only in the individual market, only for those under the age of 30. But then, you know, going down, you know, bronze in general is you know, a popular metal level. We've got 23% of the entire market on bronze. And you can see, you know, we've got people in all three types of plans. You've got, you know, a meaningful number of people in HGPs, value, and other. We pull both the enrollment statistics and statistics on the deductible and the MOOP, the maximum out of pocket is what MOOP stands for. So if you look at those bronze details, you can see that for the high deductible health plan, the average deductible is $6,400 and the average out of pocket max is $6,900. And that's well below the average for the other bronze plans. And that's because of that disconnect between the maximum IRS out of pocket max and the maximum ACA out of pocket max. And then you can see the value plan has a similarly low deductible of $63.67, slightly lower average deductible, but has a much higher out-of-pocket max, closer to the federal limit. The federal limit is $9,100 this year. The catastrophic plan is at that limit. And then you've got the other type of bronze plans, which, you know, in general have deductibles that are too high to be HDHPs. And you know, they average $8,000 deductible and they average an $8,457 out of pocket. But then you can see on silver plans that the cost shares get lower. As I said, you know, the silver HDHPs are not very popular in the individual market. There's only 1%. And I think a big reason is that, you know, the silver is where people with subsidies go. You get both the premium tax subsidy and the cost sharing reduction subsidy on silver. I'm going to go through some numbers on the next slide, but most of the people in this HDHP bucket in silver probably don't actually have a plan that is high deductible health plan, because their out-of-pocket max gets lower because of federal cost sharing reductions. But you know, in general, you can see that it's the value plans and the other plans on silver where the bulk of the silver enrollment goes. And then, you know, on the right of the column, you can see that almost half of the market is in gold. And, you know, if you add gold and platinum together, you've got 50% of the market. And a big part of that is, you know, it's been a recent shift because of what's going on with the federal cost sharing reduction subsidies. The federal government originally funded the cost sharing reduction subsidies. They defunded them, stopped funding them in 2018. And so we have to build those into the silver premiums. And so the gold premiums are cheaper than the silver premiums. And so if you qualify for a premium tax subsidy, but not a cost sharing reduction subsidy, you can get a better, cheaper plan in gold. So if you looked at the enrollment back in 2018, before they defunded CSRs, it would look drastically different. But because of that dynamic, that is why such a large portion is in these gold plans. And you can see, you know, the average gold deductible is, you know, $774 for a value plan, $1,883 for other. In general, that average is below the IRS minimum for an HDHP. And like I said, and we'll show on the small group slide, it's technically possible, but it's not in the individual market. All right, next slide, please. So this is a history of the high deductible health plan maximum versus the ACA maximum. So back in 2014, they were set equal to one another. So the original ACA out-of-pocket max was set equal to $6,350 in 2014. And then you can see across that top column that for people that are of lower incomes, they have a lower maximum out-of-pocket max. For those in the 200 to 250% range, it was set at $5,200 back in 2014. And for those in the 100 to 200% range, it's $2,250. And so, you know, the majority of people in silver are in that 100 to 200% bucket. So that's why I say that even though their base plan might be HDHP, they're probably not actually in an HDHP compliant plan. But then if you look down the columns, you can see, you know, the spread between these two out-of-pocket maxes widened, you know, every year between 2014 and 2022, the ACA out-of-pocket max went up more than the IRS did. That's driven by how the two are indexed. The IRS out-of-pocket max is indexed to CPIU all items, general inflation, you know, when the news reports on the overall inflation rate. And the ACA out-of-pocket max is linked to the overall average premium in the employer-sponsored market, as measured by CMS and the National Health Expenditure Data Report. And in general, health insurance premiums have increased at a higher rate than inflation in the past. And so that is why they have widened historically. You can see in the last 2 years, it's narrowed a little bit, that the IRS max went up a lot in the last 2 years because of the high inflation that we've as a country have been experiencing. And that, you know, the ACA out-of-pocket max also went up, you know, by a reasonable amount, but not as high as you know, as the HDHP. So, you know, things have narrowed a little bit in the last couple of years, but I expect them to go back to normal. You know, general inflation has moderated a lot. The 2025 out-of-pocket maxes won't be set until first quarter of 2024. But, you know, the expectation is they should start widening again going forward because of the different indexing rates. All right, next slide, please. So this shows the percent of members in the individual market that hit their out-of-pocket max. So this is not divided by HSA versus non-HSA. You know, to back up, you know, we do not have a lot of information available by HSA versus non-HSA because our filings, you know, as I said during the ACA part, you know, a single risk pool methodology is inherent to these ACA filings. So we don't usually need to collect the plan level data as far as demographics and geographic differences by plans. So, you know, I know you'd requested us to have the age differences between HDHPs and non-HDHPs. We don't have that information handy. We're going to be adding data calls to future rate filings to get that plan level information so we can answer questions like this, but it was not handy because you know, it has not been needed in rate review. And so also, you know, we did this data call a couple of years ago for another purpose. It did not have HSA by non-HSA broken out in that data call, but you know, I'm showing you what we have available. So this shows, you know, the average out-of-pocket max by metal level and the percentage of members hitting it. And this is all carriers combined. We had them report it for 3 years, 2019 through 2021. So in the top row, catastrophic, you can see, you know, a very tiny portion reached their out-of-pocket max in catastrophic. That's driven by catastrophic people just being healthy, that they're almost all under 30 and they're very healthy in general, and very few people have high claims. But then on bronze, you can see that you know, almost 5% of members hit their out-of-pocket max. And then it kind of goes down from there. And this was originally kind of counterintuitive to us and not what we expected. Because, you know, objectively, we've got data from risk adjustment, and bronze members on average are healthier than silver and gold members. And so we expected this to look differently. But you know, the driver for this pattern here is what services are outside the deductible. And on bronze, most of the plans subject most of the services subject to the deductible. So you can hit your deductible and you can hit your out-of-pocket max by not having a very high claims level. You know, if you have an $82.50 deductible and $82.50 out-of-pocket max, you only need $82.50 worth of claims. But if you had $82.50 worth of claims on gold, the majority of your services are not subject to deductible. You're only going to be paying a copay, and your out-of-pocket costs are not going to be nearly that full $82.50. So that kind of explains this pattern on this sheet. But you know, you can see that the silver, we broke it down by the different CSR levels to see if there was a difference. and there wasn't a huge difference. In general, it's about, a little over 3% of silver members hitting their out-of-pocket max. And gold is 2%, and then platinum is 0.6%. But like I said, that's not driven by those people being healthier. It's driven by the benefits being richer, and it's just requiring more claims to hit that overall maximum. Next slide, please. So that previous slide was the component of the market that had self-only policies. So they only have their own individual deductible and their own individual out-of-pocket max. We've separately asked carriers to give us that data for family policies, where there is a family deductible and family out-of-pocket max that's generally double the individual one. And on this one, you can see all the percentages are a lot lower. A much smaller percentage of families ever reach their family out-of-pocket max. And this is mainly driven by the more or less independent nature of claims. Claims are not completely independent versus family members. You can get COVID and spread it to a relative, but in general, large claims tend to not be correlated. And so one family member might reach their out-of-pocket max, but it's pretty rare for the family in general to have multiple members with high enough claims to reach their out-of-pocket max. Once again, you're talking about much higher absolute values of out-of-pocket maxes. Next slide, please. Next slide. I think we're going backwards now. Yeah, forward 2 more, I think. Yeah, 1 more after this. All right, so this slide shows an example of the total out-of-pocket max for 3 types of example subscriber with different levels of claims costs. So I've chosen Care First plans so that these all have the same network, and the only thing different is benefit design. These example premiums are for an age 40-year-old. Care First doesn't geo rate, so it would be an age 40-year-old anywhere. It assumes you're not eligible for APTC, so you're earning $55,000 or more, and you're paying the full cost. And it shows 3 different bronze plans that you could choose from Care First. There's the bronze 8250, which just has an 8250 deductible, and then that's your out-of-pocket max as well. So once you've paid that, you're done for the year. But that is higher than the IRS maximum out-of-pocket max, so it's not HGHP compatible. And then you've got the value plan, which offers the services I talked about outside of deductible, and then you have the HGHP, which has the lower deductible and lower out-of-pocket max. So in the top section, I've shown a healthy person. The healthiest you can be is having no claims. So if you are healthy and you have no claims, you're going to minimize your annual cost by taking that bronze 8250 plan. It's the cheapest premium out of the 3 plans. And, if you are healthy, it makes sense to, say, I want this for a catastrophe and to buy this minimum premium plan. The middle section shows somebody with $5,000 in annual claims. And this is somebody with probably some chronic conditions to manage, and in this case it's the value plan that's going to minimize their total annual cost, and that's due to all of the services that are common to managing chronic conditions that are not subject to the deductible and instead have copays. So under both the bronze 8250 and the HGHP, you're going to pay $5,000. You have your deductible, and this is $5,000 in non-preventive claims. So you pay that full amount, but under the value plan, the carrier pays a significant amount, and you come out with a lower annual cost. And then finally, in the bottom section, it shows a high cost member, $25,000 in claims. And this member is going to hit their out-of-pocket max, regardless of which plan they get. But because the HSA, the HGHP, has the lowest out-of-pocket max, that more than makes up for the higher premium, and they minimize their annual cost by being in this HDHP plan. So, there's not a one size fits all. There's no one plan that is best for everybody. This shows the range and shows that the different bronze plans are most suitable for different populations. We could do similar examples for Kaiser or for silver, but in general, there's generally not one plan that is ideal for every type of claimant. There's generally different plans for different levels of claims will minimize a person's out-of-pocket total spending. All right, next slide, please. All right, so this shows the HDAP enrollment in the small group market. I did not update the labeling here. HSA should be labeled HGHP, and non-HSA should be labeled non-HGHP. But you can see, in the small group market, HDHPs are really high market share, especially on silver. On the bronze medal level in general, small group market share is small. Most small groups want to provide more generous benefits than bronze. But you can see that the silver medal level is dominated by HSAs. This is not because of a lack of choice of non-HSAs. I mean, when you count the number of benefits, there are more non-HSAs being offered by carriers on silver than HSAs, but this reflects where the actual enrollment is. And then, as I mentioned, on gold, these HGHPs are possible design, and there is a market for that in the small group market, but most gold plans are non-HDHPs. And silver platinum is a much more popular metal level than the individual market. Platinum plans in the small group market generally have $0 deductibles. So a significant portion of small groups do go for those more generous plans. Next slide, please. So it is not nearly as easy to get small group data as it is individual data. This deductible and out-of-pocket max data we've been presenting, we can't pull from the templates, the unified rate review templates. My team has to manually pull them from the rate filings. So we do not have recent 2023 individual or small group data to compare deductibles and out-of-pocket maxes. But we did do a study for the General Assembly on the overall level of out-of-pocket maximums and how they've increased. So using that 2018 data, which is not comparable to the individual data 2 slides ago, you can see a similar story to individual in that the HGHP, what's labeled HSA here, has the lower out-of-pocket maxes that for every metal level where HGHP and non-HGHP is offered, the HGHP plans tend to have a lower out-of-pocket max. And that's kind of driven by the actuarial value considerations. They all have to hit the same range of actuarial values. And if you're subjecting everything to the deductible in order to have the same actuarial value range, you have to have a lower out-of-pocket max. So if we updated these numbers in 2023, everything but both HSA and non-HSA would be higher, but the relative relationships should in general be true. And like I said, the HGHPs in general for any given metal level should have a lower out-of-pocket max because of that dynamic. So that's all the data that I had to present to you on the ACA part. So at this point, I think any questions for David or I on the whole presentation.
Okay, is Mary going to present? Because she was on the agenda.
She's not. She's available to answer questions.
Wonderful. Well, thank you so much for the presentation. I know it's a lot. but this is an issue that often comes up during the committee, right? About these plans. So I thank you for going through it. I see some questions, so I'm going to start with Delegate Hill.
Thank you, Madam Chair, and thank you, gentlemen. David, especially thank you for that primer 101. If we go back to 13, slide number 13, and then all the slides that came after that, Brad, I want to get this, make sure I understand this correctly. So on the subsequent slides, you talked about what a person might stand to have as their total out-of-cost premiums plus deductible. But I want to be clear that what you're telling us that is less than 5% of people ever pay enough in their deductible that the insurance kicks in. So they're paying the premiums, but they almost never collect on those premium payments. Less than 5% of people. So 95% of the time the premium goes to the insurance company to pay some claims, but mostly for other purposes. Am I over interpreting this?
No, that's not what this slide is showing. So this shows that the portion of people reaching their out-of-pocket max. So these 5% of people have reached their out-of-pocket max, which means the insurance company is going to be paying 100% of their claims that are over the out-of-pocket max. So this is not measuring what portion the insurance company pays. This is measuring what portion of the pool has enough claims to ever reach their out-of-pocket max.
Right. So help me understand, if I don't reach my out-of-pocket max, then the insurance isn't kicking in at all. Or it is, I mean, in other words, this looks to me like if I'm 95% of the people that don't reach my out-of-pocket match, then the insurance company doesn't kick in.
So the out-of-pocket max is the maximum member cost sharing that can be incurred in a year. And so insurance kicks in from day one. If you have a value plan or a not HGHP plan, you've got some services subject to the deductible, some not. Anything you pay in copay is accumulating towards your out-of-pocket max. Anything you pay towards your deductible is accumulating towards your out-of-pocket max. The out-of-pocket max is your annual limit for the year when you stop paying anything and the insurance company pays 100%. So,
Right.
so we, but
So when does the insurance company pay if I haven't met my out-of-pocket max?
they can pay from day one. If you have a plan that's not an HDHP and you don't have a deductible on any service, they're paying from day one. You go to the doctor visit, you have a $20 copay.
Right, but for
The
the,
service visit is $150. The insurance company pays $130. You pay $20. If you have an HDHP, you are responsible for the whole deductible. So if you have a non-preventive visit, you're paying that whole $150 allowed amount, and you don't start having the insurance company pay until you've reached the deductible. But
so that's just for the HCPA. So it's on that group, 95% of the time it doesn't pay. Okay, thank you.
no, the 95% stat is not accurate. That is, these numbers are not what percent of people the insurance company is paying for.
So basically you have to meet the deductible first, right?
I mean, an insurance company will pay your preventive claims from day zero, but yes, for a non-preventive claim, you're responsible for 100% of the allowed amount if you're in an HDHP.
Okay, thank you. Thank you. Next, we have Delegate Taveras.
Thank you, Madam Chair. So just really quick, for me is after the high deductible, the insurance covers everything. I just want to be clear on that. And I just want to get clear on a couple of the, I don't know if there are any particular trends of what illnesses are associated.
Why don't we allow him to answer that first question and then you can go to the second, okay?
Okay.
Thank you so much for your patience. Go ahead, just to keep it clear. Go ahead, Brad.
Can you repeat that question? I'm sorry.
So after you pay into the high deductible, then after that, and you use it all, then your insurance covers 100%?
In general, for all plans, high deductible or otherwise, the deductible has to be met on certain services, and you, the member, are paying 100% of allowed amount until you reach your deductible. Then after you reach your deductible, you are in a cost sharing phase with the insurance company, and you are either going to have co-pays or co-insurances. It depends on your plan and it depends on the service. But then after you've reached your deductible and the co-insurances and co-pays, the out-of-pocket max limits that. And so that is when the insurance company starts paying 100%. So before the deductible is met, you pay 100%, the insurance company pays nothing. After the deductible is met, before your out-of-pocket max is met, you're paying a copay or co-insurance. The insurance company is paying more than you are in general. I mean, the copay or co-insurance is going to be the minority of the claim. The insurance company is going to be covering the majority of the claim, but then your out-of-pocket max says you've paid enough for the year, and then the insurance company pays 100% of all claims after you've reached your out-of-pocket max. And that's what that slide was showing. That's what the 5% was. Those 5% of people reached their out-of-pocket max, paid the maximum they had to pay for the year, and the insurance company covered 100% of all their claims once they reached that.
Got it. That's a lot clearer. Any particular illness trends for people who use this?
No, I mean, we don't have data on illness or morbidity, but by HDHP versus non-HDHP.
And for us newbies, I was able to decipher a lot of the acronyms, but the one that I could not is APTC. What does that mean?
Yeah, sorry. That's advanced premium tax credit. That's only available in the individual marketplace. But that's the subsidy that helps lower the premiums, and that you then reconcile on your federal tax forms.
Got it. Thank you.
Thank you again for your patience. Next, I have my wonderful Vice Chair, Delegate Collison, who will be taking over now until we end. We're almost at the end. I just want to say thank you to everyone for, especially our members and our guests, for coming. I know this is dense, it's heavy, but these questions often come up during session, and it's best to digest them now. And also, the commissioner is really available, and her staff. I mean, you can reach her, and she's always very responsive if you have any questions. Thank you so much again. I appreciate it. Delegate Collison, you can take over.
Thank you, Madam Chair. And have a great afternoon, rest of afternoon. So this information on the high deductible health plans is fantastic. Thank you so much for putting it together. I understand so much more about them now, and I can see some of the comparisons. My question is, who helps people understand them? Because they are very complex, and understanding the relationship between the HSA with a high deductible plan, and whether or not your employer is going to be contributing or not. So how does someone learn how to pick one of those plans or not? And I mean, I guess the question is, how are people advised or learn about picking the right insurance plan for them based on knowledge of maximum out of pocket cost and co-insurance and co-pays, et cetera. So it's sort of an esoteric question, but I think because the high deductible plans are so complex, I know I have heard from many people who have them who had no idea probably of some of the advantages, and that while their deductible seems high, their actual out-of-pocket cost may be less than in another plan. So who helps them?
So I think this is maybe one that I can help with in the sense that that is a very important question, and it really depends on your market, right? So for example, in the individual market, if you are looking at the benefit exchange, the health benefit exchange and the connector, you have the ability to make lots of comparisons, but you also have the ability to talk to a navigator about what makes sense to you. And during those conversations, you can get information about how this plan would operate and what it means for you. But outside of that program, what most people rely upon are the insurance producers that we license at the Maryland Insurance Administration. And so, for example, if you have an employer-based plan, there's usually an open enrollment period. Information comes to you from the employer, often through the broker. They may have meetings and timeframes set up to have someone come in and talk to you about what makes sense if you have lots of choices. Certainly in the large employer setting, you often have a benefit administrator who is available to answer employee questions. But I would say the backbone of education for consumers is the agent sales force and licensed insurance producers. And then I would say for the average person, another line of defense, another line of information is, frankly, we try to be there, is Joy Hatchett and our consumer education and advocacy unit that does multiple webinars a month in a variety of products. And we can't guide people in their individual choices, but we can educate them about what terms mean and encourage them to seek out the assistance of a trusted advisor. So I would say the connector provides a certain level of information for people that are seeking individual coverage through the exchange. And then it is a set of benefit administrators and individual agents who are available to guide people.
Thank you, Commissioner. That's really helpful. And I think it's probably important for us to figure out how to make that known in terms of where people can get those resources. And I know the MIA is one very important part of that. So thank you. Are there any other questions from the committee? Everyone's going to be studying this over the next couple of months, right? Okay, I don't see any other questions. Then I too want to add my thanks to the MIA and your team, Commissioner, for a fantastic job, and also for letting us know that we can get in touch with you when we have questions. And I would encourage committee members to do just that. If you have specific questions about insurance, they are an amazing resource. And to the committee members, welcome to October, when our work really begins to ramp up. And it was so good to see all of you, albeit in the small screen, but I look forward to when we can have a chance to get together in person again. Are there any questions for the committee not related to our agenda today? Okay, thank you all very much. Delegate Taveras.
Are we gonna have a conversation about, well, I guess I don't know, the Maryland Insurance Administration is ever going to be discussing, maybe with some other committee, with regards to the fact that insurance companies are no longer covering individuals for natural disasters?
That would fall under the Economic Matters Committee. So
Okay.
we
I'll
can
look out for that.
talk to them.
All right, thank you.
Okay. All right. Well, then you all have a wonderful afternoon. Thank you so much for your time today.